My name is Craig Gordon, and this is Jean Francis. We'll be speaking for the next little bit about atypical hemolytic uremic syndrome, updates, challenges, and progress. This session is supported by an educational grant by Alexion, and I think with that, let me get started by introducing Dr. Francis. So it's a real pleasure to be here with my colleague, Dr. Francis, who obtained his medical degree from the Lebanese University School of Medicine. He completed medicine residency and nephrology fellowship at Yale University St. Raphael campus, and he subsequently did a kidney and pancreas transplant fellowship at BI Deaconess Medical Center and Harvard Medical School. He is currently the medical director of kidney transplantation at BU Medical Center and the medical director of the combined pancreas transplant program between BU Medical Center and Brigham and Women's Hospital. Dr. Francis conducts clinical research in kidney transplantation and has a special interest in thrombotic microangiopathy and complement-mediated diseases. He is also an accomplished educator who has won several Excellence in Teaching Awards. He is recipient of the 2022 National Kidney Foundation Award for Excellence in Nephrology and Transplantation. And Dr. Francis serves as co-director of BU's Thrombosis and Microangiopathy Collaborative. So welcome, Dr. Francis, and thank you.
Thank you so much, Dr. Gordon. Thank you all for being here. And, my part, I'm going to today be talking about the pathogenesis, the overview of genetic mutations that lead to atypical HUS, and also I'm going to be discussing briefly the new nomenclature that has been released by a group of experts. And to start, those are my disclosures. And the objectives, I'm going to be talking about definition and clinical presentation of AHUS in brief, because I think Dr. Gordon will cover that part in more details. I'll talk a little bit about the new nomenclature for TMA syndromes, the pathogenesis and genetic mutations, and the pathophysiology of AHUS. And I will hint to therapy because Dr. Gordon is going to go more in detail on that. So what is hemolytic uremic syndrome? It's a thrombotic microangiopathy that usually manifests with a microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. On the left side here, you see a normal glomerulus with happy-looking open capillary lumens. And on the right side, you see a glomerulus hit by thrombotic microangiopathy. You see this diffuse thrombosis and microthrombi formation filling up those capillary lumens. In its classical form, which was described in the past, it's the first type of HUS described. It is usually preceded by a diarrheal prodrome, which is usually associated with certain infections like an E. coli or strain 0157 or 0104, sometimes Shigella, and those bacteria secrete Shiga toxin, which could lead to the hemolytic uremic syndrome. They're more common in pediatrics, and most of those cases usually recover, although sometimes they leave some CKD. In its atypical form, and this is the part that we are interested in here today, it is usually associated with mutations affecting the complement regulatory proteins. It has a poor prognosis. 50% can end up with end-stage renal disease, 25% can die if they are not treated appropriately. And importantly, it recurs after kidney transplantation at extremely high frequency. When we say microangiopathic hemolysis, you have to remember that in the peripheral smear, if you examine it, you're going to see those helmet-shaped cells. We call them schistocytes. And those are very important to make the diagnosis of microangiopathic hemolysis. And they are just some fragments of RBCs that have been destroyed when they're trying to squeeze themselves into between the microthrombi that are filling the microcirculation in different organs. And you need 2 of those by high power field or more to call it positive schistocytosis. On the slide here, you're going to see those also in kidney biopsy. You see those capillary lumen filled with microthrombi. And also, if you go in depth by electron microscopy, you're going to see severe endothelial swelling and a layering of fluffy material under the endothelium, giving thickening to the basement membrane and lamellation, which usually our pathologists read it as active on chronic thrombotic microangiopathy. So when patient arrives in the emergency room, they often have this microangiopathic features where there's a hemolysis with drop in hemoglobin, there's a drop in aptoglobin, an increase in LDH and the schistocytes. They might not be present on admission. You have to do serial testing. They might appear later on and during the admission. They have thrombocytopenia, and they have sometime a drop in their complement level, especially C3, which is present in 40%, 40% of the cases. We automatically rule out TTP and rule out chigatoxin by doing special testing. And people also have, patients also have one or more organ dysfunction due to those microthrombi that are happening in the microcirculation. So the differential diagnosis is quite large. And, in my institution, where I work, in Dr. Gordon's institution, we both build TMA teams because of the complexity of those cases. And we work very closely with all the consultants to kind of try to grasp all those patients who come to our hospitals with TMA and go through the differential diagnosis. Dr. Gordon will elaborate on that screen, but I just want to tell you, first thing you need to do, rule out TTP, because you need to treat urgently with plasma exchange. If this is not TTP, you're dealing with either a complement-mediated TMA that we call AHUS, and the new nomenclature wants us to call it something else, but also, there is a variety of triggers and secondary triggers that can cause TMA, from infections, viral bacterial parasites, vaccinations, cancers, malignant hypertension, pregnancy, etc. There's a big list, and drugs. So there's a lot of secondary triggers that can cause TMA that you need to think of and try to rule them out. And if you can't, by history, by testing, by exam, find any other trigger, I think you're left with the possibility of complement-mediated TMA and AHS, and you have to act accordingly. So what about the new nomenclature, and why is it needed? So people are trying to discard, I think a group of experts met and they kind of discussed at large, if a change in nomenclature is required, and they all agreed it is required, and they made the decision to discard the word AHUS, or atypical hemolytic uremic syndrome, as it does not indicate a disease mechanism. It just tells you that this is not a chigatoxin-mediated hemolytic uremic syndrome. So in the past, if you're not chigatoxin, you're atypical hemolytic uremic syndrome. So it does not underlie any mechanism of disease. And everybody in the group favored the term TMA over HUS. And the reason for that upon disease, on disease presentation, sometimes, there's no renal failure. Patient presents with hemolysis and the features of hemolysis without yet organ damage. So they preferred the term TMA. And some forms also do not present with microangiopathic hemolytic syndrome. They only have renal limited TMA that is discovered on kidney biopsy when you do it to try to identify why the patient has AKI. So they felt a TMA the term TMA would be more appropriate to grasp all the features of presentation. They also, in front of each TMA, they tried to add the suspected trigger that can cause the TMA. And I'll show you on another slide, make it much easier to understand. And, they wanted also to keep this nomenclature fluid. Like if you label it hypertension TMA and you address the hypertension that does not improve, you need to be fluid in your management and move to other etiologies as much as the clinical picture is clarifying in front of your eyes, or you're doing more testing. So you need to progress from one disease to another until you are sure what you're treating. And this is the slide I'm talking about. So if you know the trigger, and there are plenty of them, so they want you to name it according to the trigger. Is it a pregnancy-induced TMA? Is it a bone marrow transplant-induced TMA? Is it a solid organ-induced TMA? Or malignant hypertension-induced TMA, drug-induced TMA, cancer-induced TMA, and vasculitis-induced TMA. So they gave those are the known triggers. And if you remember in this differential diagnosis I showed you before. And at the end, also, it could be infection-mediated TMA, either by chigatoxin, viral infection, sepsis, or some strep pneumo infections. If you don't find a trigger, if you cannot grasp a trigger, They want you to go on the second line and rule out TTP. And then if TTP is ruled out, it's time to start thinking about the possibility of complement-mediated TMA. That's what we call AHUS. And then, this could be proved by the presence of genetic mutation in the complement system. They call them GCTMA, which means there's genetic mutation in the complement system. Or you could have an autoantibody against factor H, anti-complement factor H antibody triggering or driving the TMA. Or you could have a complement-driven TMA, but without a genetic mutation, and we know those exist in 30–40% of the time. But you could also have other mutation not affecting the complement system that could lead to TMA, and they list here DGKE, I'll talk about it a little bit at the end, and other mutations like XEN and inverted foramen and exhaustin. Those cause some neurological disorders, especially the XEN and the exhaustin associated with TMA. So there are some other genetic mutations that have been involved. Or you could be dealing with a metabolic-induced TMA, like cobalamin pathway deficiency or vitamin B12 deficiency, or it could be an unspecified TMA. So this is how the group found, they want to link to a trigger, and then if the trigger is not identified, move and be fluid in your differential diagnosis. So I think Dr. Gordon is going to go over that. I want to focus now. I'm going to continue to call it atypical HUS until the nomenclature is approved and is formalized and is going to be what we're going to be using going forward. So it is not induced by Shiga toxin. It is often recurrent and may cause permanent kidney damage, may cause neurologic and other organ damage, and it frequently recurs after kidney transplantation. It could be sporadic or familial, and it is usually linked to abnormalities in the complement regulation. Bear with me on this slide. I know you all love the complement. This is why you're here. So the complement could be activated via 3 pathways: the classical pathway, the lectin pathway, and the alternative pathway. Even those pathways, they're going to lead to the activation of the alternative pathways. It is believed that 80% of the complement activity is driven by the alternative pathway. Back to the alternative pathway, which is of great interest for us here today, it's constantly ticking. There is a low level of activity in all of us. Every second of our life, we're generating active complement products. It's like a ready system to be activated upon a trigger, like an infection, surgery, drug exposure. Any trigger can really revamp and accelerate the activity and make it bigger and bigger. But we don't get sick, and we don't destroy our organs. And the reason for that, even though we're producing those active complement byproducts and they're depositing in multiple places in our organs and our kidneys and our blood vessels on the surface of the endothelium, and the reason for that, because we have all those regulatory proteins. Some of them are circulating in the blood. Some of them, like thrombomodulin and MCP, are expressed on the surface of the endothelium. So anytime there is an active byproduct of the complement depositing or circulating, it is attacked by those regulatory proteins and it's destroyed. So imagine you have a trigger and you have a deficiency or absence or dysfunction of some of those regulatory protein, you could end up with developing atypical HUS. So what are those mutations? The most common and the most severe form of mutations are mutations affecting complement factor H, and 90% of them affect those 2 short consensus repeat, 19 and 20. We call it the C-terminal part of factor H. This is highly important. Those 2 short consensus repeats, 19 and 20, are very important for the binding of factor H on the surface of the endothelium to execute its regulatory activity. So if they don't exist, factor H cannot bind, and then you cannot regulate the activity of the complement. And I'll show you more animation of that to make it clearer to you guys. The other mutations described affect complement factor I, which is a protease that degrades the real complement byproducts with the help of factor H. Some mutations are gain-of-function mutations affecting C3 and complement factor B, rendering them resistant to the decay activity of factor I and factor H. And there are some proteins, as I told you, expressed on the surface of the endothelium, like MCP and thrombomodulin. If they are mutated, also they could trigger atypical HUS. Sometimes there is no mutation. What you have a circulating autoantibody, like anti-complement factor H. This antibody binds to the short consensus repeat 19 and 20 and blocks the activity of factor H, preventing its binding to the surface of the endothelium to protect us. So if you take 100 patients with AHUS and you do genetic testing and you test them for every genetic mutation known on Earth, you will find that 50–60% of them have a known mutation. The other 40% or 50%, there is no mutation. And we know now more and more what are the other mutations or trigger that are leading to this disease. We're not going to cover that today. So in summary, atypical AHUS may arise when there is deficiency, dysfunction, or autoantibody-mediated inhibition of one or more of the regulatory proteins, or if there is a resistance of C3b and factor B to the decay activity of factor H and I and MCP, or if there is a mutation in thrombomodulin, which is an endothelial glycoprotein with cytoprotective and anticoagulant properties. But that's the most important thing. The disease will remain quiescent for months or years or decades and not manifest itself even in the people who have the most severe mutations, homozygous deletion, until there is an innocuous trigger, like an infection or surgery, pregnancy, something comes at a certain time in the life of the patient and triggers the disease. So this incomplete penetrance, we'll talk about it in another slide. So I'm going to show you some animation to make you understand, the mutations and how they affect the function in our body. To understand that, I'm going to remind you of factor H. I told you those two short consensus repeat 19 and 20 and 7 are very important for factor H to bind on the surface of the endothelium. It actually binds on the glycocalyx of the endothelium. And those short consensus repeat 1 to 4 are very important for the regulation and the help of factor I to degrade whatever factor I needs to degrade. So let's take a look. That's factor H. That's the N-terminal part, and that's the C-terminal part. And remember, the complement exists in two phases in our body. It exists in a fluid phase, and this is the most abundant phase. There are proteins circulating in the blood, in the plasma. And also there is byproducts of the complement that deposit on the surface of the endothelium. They also need to be regulated, and this is what we call the solid phase. So the N-terminal part of factor H is very important for the regulation of the fluid phase, and the C-terminal part of factor H is very important in the regulation of the solid phase. Let's see how they work. So as soon as factor H binds to C3b, big B, little b, which is the C3 convertase in fluid phase, it dissociates big B, little b from C3b, gives access to factor I to degrade C3b into its inactive form, and the complement activity is shut down in the fluid phase. Whenever C3b binds on the surface of the endothelium, factor H comes with its C-terminal part and binds to the C3b, and this gives access to factor I to degrade C3b into its inactive form, and the complement cascade is shut down also, and those byproducts are degraded on the solid phase. So let's see if we have mutations now, what's going to happen. So now I'm showing you a factor H with a mutated short consensus repeat 19 and 20. So it cannot bind to the solid phase, it cannot bind to the endothelium and regulate the solid phase. The fluid phase goes unimpeded. It's working nicely. There's no problem with the N-terminal part. But now, because factor H cannot bind to the surface of the endothelium, factor I is not able to degrade the active C3b into its inactive form, and this leads to the terminal complement cascade activation, generation of the membrane attack complex, which binds to the endothelium, perforate the endothelium, and cause AHUS. So AHUS is a disease of the solid phase regulation of the complement. So sometimes you don't have a mutation in the factor H, so the fluid phase goes unaltered, it's functioning, there is regulation, but now factor H cannot bind because there's an antibody blocking its binding, and this is what factor H does. So again, factor I, without the help of factor H, cannot degrade C3b into its inactive form, terminal complement cascade is activated, membrane attack complex is formed, AHUS will develop. So what happens now if you have a mutation affecting the N-terminal part of complement factor H instead of the C-terminal? So the regulation at the surface of the endothelium is working nicely. There is no problem. Factor H binds, regulate the solid phase, and there is no disease, no AHUS. But now the fluid phase is unable to be regulated because of the mutation affecting the N-terminal part of factor H. So big B, little b cannot be dissociated from C3b. Factor I then is not able to degrade the active C3b in the fluid phase into its inactive form. This would lead to the terminal complement cascade activation in fluid phase, leading to the generation of soluble MAC that deposit in the subendothelial space or in the mesenterium, and many byproducts of C3 will also deposit, and this leads to the development of C3 glomerulopathy, like C3GN or dense deposit disease. So if you are to remember something, in 80–90% of the time, the fluid phase dysregulation is a cause of C3GN and dense deposit disease, and the solid phase dysregulation usually is what causes the AHUS. So what about MCP? If MCP is normal, it binds to C3b, helps factor I to degrade it into inactive form. But if it is mutated, it cannot do this work, and then this leads to the generation of membrane attack complex and can cause AHUS if there is a trigger. What about having a C3 mutation that renders the C3 resistant to the decay activity of factor I? The same, factor I, even in the presence of normal factor I and normal factor H, it cannot degrade a resistant C3b. It's a gain of function mutation. This also would lead to the membrane attack complex and leads to AHUS. I want to highlight some hybrid proteins that have been described and makes it, it's interesting to understand them as causes of AHUS in rare circumstances in certain families. So there is a high homology in the regulators of the complement activation in the gene cluster. So factor H comes on the same chromosome with many other complement factor H-related peptides. They go from number 1 to number 5, and they are very important regulators of the activity of factor H. Sometimes some recombination can take place. For example, here, short consensus repeat 20 is knocked off and it's replaced by recombination by the short consensus repeat 5 from the complement factor H-related peptide 1. So this becomes a dysfunctional complement factor H. You cannot execute this hybrid protein between the two is dysfunctional. And some families have been described having this mutation and having AHUS. Another form would be short consensus repeat 20 from factor H moves and bind to the factor H-related peptide 1, forming this hybrid protein we call factor H-related peptide 1 complement factor H hybrid protein. So now you have the short consensus repeat 20 competing with the normal factor H on the binding site on the endothelium, prohibiting or inhibiting the binding of the normal factor H, and that's, leads to inability of factor H to regulate the complement, and some people can develop AHUS like that. So those hybrid proteins have been described to cause some forms of AHUS in certain families. Sorry. I'm going the wrong direction, excuse me. So what about the incomplete penetrance of the disease? This is a family from Italy. You can see 2 kids died at very young age from AHUS, and they have a known mutation in complement factor H. Their brother at age 4 developed AHUS and died and remained on dialysis since age 4. He didn't die. Their father carries the same mutation, never manifested the disease, but their grandfather developed AHUS at age 82, and they all carry the same mutation and died from AHUS at age 82. So he lived all his life without having any manifestations of the disease, just to show you how is variable the penetrance for this disease. So if anything, regardless of the mutation that I just described, hybrid proteins, factor H, factor I, resistance C3, whatever is the mutation, the ultimate goal of the complement in AHUS is to activate C5 and split it into C5a and C5b and causing the production of the membrane attack complex. So if you have a drug that can block C5 splitting into C5a, C5b, and then you can block the terminal cascade of the complement and really cure AHUS and prevent any progression of the disease. So Dr. Gordon will be talking more about those treatments, available drugs. Briefly, I just want to mention that This disease can recur about after transplant. There's a high recurrence rate, and if it recurs, it would lead to graft function without treatment, and up to 100% of the time. It's very, very severe disease. You could say that MCP mutation should never recur after transplant. If you're giving a kidney with normal MCP, it should protect the graft from any complement activation. Still, with MCP mutation, there's 15% of the patient would recur with AHUS. And the reason for that is in MCP mutation, 20 to 25% of them, they have, in addition to MCP, they have other mutations in complement factor H, complement factor I, or other mutations. So always, always, if you can, and if you have access and you have the ability to do a genetic testing before transplantation, it would be very important to guide you how to treat those patients and how to monitor those patients. I want to say a brief word about this recessive mutation in DGKE that can cause AHUS syndrome. So homozygous or compound heterozygous mutation in DGKE, which encodes for the deacylglycerol epsilon. It's a protein expressed in the kidney, in the podocyte, and in the endothelium. So they were found in 27% of AHUS cases with onset before the age of 1 year. So it's a pediatric disease. And there is something peculiar about it. Patients who have this mutation in their TMA, they develop nephrotic range proteinuria and sometimes nephrotic syndrome. So if you see this combination, very young kid with AHUS and nephrotic syndrome, you have to think of this mutation. And it's tested for, with all the genetic testing we do, they test for this mutation. It is not integral protein of the complement system. It has nothing to do with the complement. Patients treated with eculizumab did not respond, and even they relapse while they are on the treatment. It walks and wanes the disease. They relapse while they are on eculizumab. So what does this protein do? A knockdown animal model of DGKE on endothelial cells upregulated ICAM1 and led to enhanced binding of the platelets and activation of the platelets and platelets clot formation. So it seems to play a role in the coagulation. Oh, what did I do? I think we go to the questions now. You want to open your apps? So the first question, the most common mutation in complement regulatory proteins leading to AHUS is homozygote mutation affecting complement factor H, heterozygote mutations affecting complement factor H, mutations affecting complement factor I, or mutations affecting MCP. Is it done? Still fluctuating. Excellent. So I think I think the majority got the answer correct. Believe it or not, it's heterozygous mutations are the most common mutations described. And what happens is, I just wanted to give a teaching point with that the normal factor H is blocked by the abnormal factor H, and it causes this autosomal dominant negative effect, if you want. So they interfere with each other, and the abnormal protein blocks. Like you can infuse factor H, they're not going to respond. As long as there's abnormal factor H, it will interfere with the activity of the normal complement factor H. So I think the majority got the answer correct. And yes, heterozygous mutations are the most common. The next question is, the absence of genetic mutation in complement system rules out AHUS, usually is seen in 40 to 50% of the AHUS cases, is enough to stop eculizumab therapy, suggests very low risk of recurrence after kidney transplantation. Oh gosh, we got it. Yeah, you're right. So it is present in 40 to 50, and some people without genetic mutation can recur, although the risk is less, but they can recur. And in treating initial presentations, I don't want anyone to rely on genetics. You have to rely on clinical. But stopping the drug after 6 months or 12 months could benefit from genetic testing, I would say. Okay? I think with that, I'm done. And it would be my pleasure to introduce my co-chair and our speaker, Dr. Gordon, who I know for the past 20 years, maybe. So Dr. Gordon is professor of medicine at Tufts University School of Medicine, and he's a nephrologist at Tufts Medical Center. Dr. Gordon is the director of the Polycystic Kidney Disease Center of Excellence, and he's also the director of the multidisciplinary thrombotic microangiopathy team at Tufts. Dr. Gordon has served on the evidence review team for multiple KDIGO guidelines, including the 2025 guidelines on ADPKD, the upcoming KDIGO guidelines on AKI/AKD, and on the chapter updates of the KDIGO guidelines on glomerular disease, including lupus nephritis, ANCA vasculitis, and the upcoming updates on IgA nephropathy and pediatric nephrotic syndrome. Dr. Gordon's clinical practice focuses on PKD, glomerular diseases, and thrombotic microangiopathy. Welcome, Dr. Gordon.
So thank you for the introduction, and thank you to the organizers for the opportunity to discuss here. In the next 25 or 30 minutes, I'm going to have a big task of trying to cover the diagnostic workup and diagnostic pathways and management strategies for thrombotic microangiopathies, including atypical HUS. I will make a brief comment as one of the co-session chairs that questions that we're going to receive via the app will address after the two talks. So I apologize for those of you who've already asked questions. Here are my disclosures, and my objectives for this session is to review a diagnostic approach to TMA, highlight the etiologies of primary as well as secondary TMA and clinical clues towards these diagnoses, review some of the particularly challenging scenarios where it's difficult to diagnose the presence of or etiology of TMA, discuss diagnostic tools that are available to help facilitate making these diagnoses, and then I'm going to focus a discussion briefly related to management on some of the more challenging questions and issues that arise. So I'm going to begin with a case which Dr. Francis and I co-managed quite a while ago, which is a 26-year-old male who had CKD5 of uncertain etiology and was referred for transplant evaluation. We did consider the possibility of TMA as the cause of his kidney failure because no one really knew why he had CKD5, and LDH and haptoglobin were assessed, which were normal. We attempted to obtain genetic testing, but this case is probably about a decade ago, and we had difficulty getting the insurance to cover it. So he had a sister who was a good candidate as a donor, and he underwent live donor transplant from the sister. And in his post-op course, he had delayed graft function. His platelet count declined to 43,000. His hemoglobin to 8.6. This was on post-op day 2. At that point, his creatinine was sort of stuck and fixed at 4.3. And notably, calcineurin inhibitors were not started, and that was the routine at the medical center. So he hadn't had this confounding exposure yet. So I'll get people woken up a little bit by starting with an audience response. So all of the following diagnostic tests are indicated at this point in time, except choice 1, haptoglobin, choice 2, LDH, direct antiglobulin test, DAT, genetic testing of the alternative pathway of complement, or examination of the peripheral smear. Give another moment or two. We have 50-50 here right now. And we're going to go back and forth. We're going to end the drama and to say that probably the best answer from our standpoint would be the genetic testing of the alternative pathway. And this is a point Dr. Francis alluded to earlier, that you don't need this. It's a clinical diagnosis. For those of you who weren't sure about DAT, yes, in this circumstance, we're probably not thinking about one of the conditions that would be a DAT condition, but this is something we can rule out. And I think one important factor to think about when you're facing these patients is when we're seeing them for the first time, it's not obvious it's a TMA case, right? We're discussing this from the perspective of, oh, it's obviously a TMA case. But when you're seeing people in the hospital with thrombocytopenia, anemia, and AKI, actually the vast majority will not be TMA, right? They'll be hemolysis through the VAD or some other type of entity. And actually, in our experience, actually, TMA is actually very much the minority, okay? So regarding the workup of this individual, his LDH was quite elevated at 1,500. His haptoglobin was undetectable. The DAT test, my apologies for the 50% of you who like that, was negative. And at this point, our conclusion would be this could be TMA, but we need additional workup. I'm going to present a similar set of slides to what Dr. Francis showed to consider the differential diagnosis. We don't want to make a leap of faith into what's going on because that could really steer us in the wrong direction. So you saw the slide earlier. TMA is evidence of MAHA, so suppressed haptoglobin, elevated LDH, and presence of schistocytes. As you can see in the middle, let me try to get this pointer here, thrombocytopenia can be either absolute or relative thrombocytopenia, so a decline of 25% or more from baseline. Dr. Francis earlier talked about the complement, which is low in only about 40% of cases. And before we start going heavily down the TMA pathway, we want to exclude TTP by checking Adams TS13 activity and rule out, in appropriate cases, STEC TMA. The end organs are key here, right? We're all in a nephrology audience here, and from a nephrology standpoint, the kidney is involved in virtually all of these cases, but there can also be CNS involvement. I'll talk a little bit more about this later, GI tract, as well as other organs. So I'm just going to briefly give a sense of complement. I think you heard a beautiful talk in the last half hour about this, but I just want to come back to this point. So normally, the complement tick-over process that's occurring in the alternative pathway is regulated by regulatory proteins, and here is factor I, here is factor H, and here is MCP or CD46. And you can see here, these are exerting fairly strong brakes on the system. So as Dr. Francis described, in the face of an infection, the system is turned on, and subsequently the inhibitory proteins shut it down when there's no more need for complement. If you have a patient with either a genetic or an autoantibody to one of these regulatory proteins where suddenly they're not exerting as strong an effect, you can see here the lines are a little bit fainter, the inhibitory lines. You get overactivity of complement as represented here in the heavier green lines, including elucidation of much more C3A, C5A, and the C5b through 9 membrane attack complex. So when we're evaluating patients with TMA, again, to take the step back to realize not all anemia, thrombocytopenia, and AKI is going to be here. In a lot of these cases, we're going to be shunted off this pathway even before then. But when we see a potential TMA case, the first thing we want to do is rule out TTP. That's done by Adams TS13 testing. That result sometimes comes back quickly in some of your hospitals and sometimes not so quickly. And one of the clinical pearls to be aware of is while you're waiting for those results, a patient who doesn't have severe thrombocytopenia and doesn't have a major increase in creatinine is less likely to have TTP. So let me restate that. So if they have a platelet count greater than 30,000 and a creatinine greater than 2.25, they are highly unlikely to have TTP. Yes, we want to wait for the Adams TS13 result, but those are patients where you probably can start thinking about other things rather than pulling the trigger on plasma exchange. When we shift further down this pathway beyond TTP into TMAs, we start to think about whether there's an underlying triggering condition, as Dr. Francis alluded to, and I'm going to go into this in more detail. Is there no condition or is there an underlying condition? If there's no obvious underlying condition, now we're looking at a potential complement-mediated TMA, and we have to evaluate, is this hereditary or acquired? Hereditary would be due to mutations in the complement regulatory proteins, and acquired would be due to autoantibodies. The important distinction there is hereditary cases we're going to treat with complement inhibition, and acquired cases we probably also will use complement inhibition, but also immunosuppression to reduce the autoantibody formation. If we're dealing with a trigger or condition, these are divided in this slide into those that are more blue, which are, as I'll show you a little bit later, less likely to be things where the genetic testing is worthwhile, versus these here in a mix of red and blue, almost purple, hypertensive urgency, pregnancy, and kidney transplant, where the yield of genetic testing is a little bit higher, and that potentially argues for people who might more benefit from complement inhibitory therapy. This group here, infection, drug-induced, et cetera, are conditions where you might want to treat the underlying trigger first, see if the patient gets better, and if they don't get better, think about complement inhibitory therapy. So you just saw the slide a little while ago from my colleague. I do want to go through it in a little bit more detail just to highlight the role of many different infections causing TMA. These include viral infections ranging from viral hepatitis to CMV in our transplant population, among many others. Bacterial infections, strep pneumoniae is a fairly common cause. And if we move along here, parasitic infections, vaccination, both solid and hematologic malignancy. I'm going to speak a little bit later about the challenges of malignant hypertension. We heard a little bit earlier about pregnancy from my colleague, autoimmune disease, and this is one of the sources of autoantibodies in many cases. So this includes lupus SLE and antiphospholipid antibodies, as well as scleroderma. Bone marrow transplantation, as well as solid organ transplantation, like the case we're evaluating. B12 deficiency used to be something we think about as only genetic abnormalities in B12, but there are clearly quite a few cases now reported of acquired B12 deficiency leading to TMA, as well as pancreatitis and a wide range of drugs. And the drugs include the calcineurin inhibitors we're all familiar with, as well as a variety of chemotherapeutic agents. Listed here is cisplatin and gemcitabine, but there are also many cases over the last numerous years of VEGF inhibitors. There's case reports now of CAR-T, protease inhibitors, and other treatments on the nephro-oncological side of things as triggers. And a number of other agents I will pass by discussing today. We do, of course, want to rule out Adams TS13 deficiency and TTP. But in the absence of finding one of these triggers, now we're looking at a real atypical HUS or complement-mediated TMA. So just before I move forward, to reiterate, faced with a TMA, we're going to rule out TTP. We're going to rule out STEC-HUS in an appropriate candidate, perhaps cobalamin deficiency, and then we're trying to evaluate secondary versus primary TMAs. So let me present some evidence from a large registry from France that was published a few years ago now. You can see here that they have in the top row about 560 individuals in this registry, so it's a quite sizable population of TMA patients. Importantly, in these first two columns, you can see here the primary TMAs, and by this we're referring to TTP and AHUS without any trigger, are actually the minority of the cases. There's only about 30 or so out of the 500 or so cases. And all the entities we talked about, ranging from infection to pregnancy to autoimmunity, et cetera, were seen in their patients and their experience in their registry. I think when I think about this, I always try to take a step back and think, if you're evaluating your own medical center, who are the patients you're going to see are going to be based on what your center looks like. So if your center is a cancer center, you're going to see a lot more of the oncological triggers and perhaps medication triggers. If you work in a hospital that's more in a safety net type environment, you might see more of the malignant hypertension, et cetera. So when you reflect on your practice, it's going to be very different depending on the makeup of the hospital. It's a disease of young people across the board. And the time-honored idea of TTP that we were all taught way back in med school with the PENTED and the neurological thing is probably fairly correct. About 90% of the people with TTP had neurological type presentation. And I do want to point out that those with TMA from other causes also, as we alluded to earlier, had neurological presentation. It's just not as common. What we understand about platelet counts, I alluded earlier to the fact that you could probably exclude TTP if the platelet count is not really, really low. Turns out that's probably true in their registry. The mean platelet count in those diagnosed with TTP was 10,000 with a range, I think, sorry, I'm getting visual acuity issues, up to 16,000. So it's really, this is a disease of severe thrombocytopenia. In contrast, as you can see across this row here, the platelet count in people with primary TMA, primary HUS, and all the secondary causes had platelet counts that were quite low, but nowhere near as low as the TTP. The converse is true regarding kidney function. The TTPs, the mean creatinine was about 1.2, so very unimpressive. Again, getting to the point I made earlier, the TMAs generally had quite elevated creatinines and quite severe AKI. The only two outliers there are pregnancy, where they had the typical dilutional effect on creatinine, and malignancy, where I wonder if that's just a component of low muscle mass and just being sick. The people with malignancy as a cause of TMA, it's late stage in their malignancy. It's really an end stage phenomenon. The French series found exactly what we discussed before, same set of potential triggers. Infections, the same list of bacteria, ranging from pneumococcus to staph and strep and E. coli, viral infections, pregnancy, malignancy, among drugs, calcineurin inhibitors, gemcitabine and VEGF inhibitors, and likely the latter increasing over time if they redid their registry and redid this publication, transplantation, and autoimmune disease. So Dr. Francis spoke a bit about genetic testing, and I wanted to highlight where this really serves a role. So this is a review from Ficori and colleagues in France, and what they found is that the yield of genetic testing depended on the condition. So you can see here presented in sort of the peach color were individuals where they found either a pathogenic or likely pathogenic variant. And in the sort of, I guess like turquoise color, were variants of uncertain significance. You can see here, unsurprisingly, if you diagnose AHUS in pediatric patients, the yield of genetic testing is really good. It's about 60% will have a positive test. If you diagnose AHUS in the absence of hypertensive emergency in adults, again, high yield of genetic testing. If you are facing a pregnancy-associated HUS, again, about 50% will test positive with genetic testing. And AHUS with hypertensive emergency, not quite as high as without, but still about 40–45% where the genetic testing is positive. And what this reveals is basically genetic testing tells you that you might want to continue your therapy of complement inhibition longer. And I'll come back to that a little bit later in the talk. The other conditions, some of the secondary causes, the Shiga toxin, among others, really had rates of positive genetic testing comparable to healthy controls. So these are probably genetic polymorphisms and not actually true pathogenic findings. So this is a complicated slide, but I just want to highlight here the role of some of our testing. So starting here in the bottom, genetic testing is thought to be of good value in primary HUS, in the post-transplant cases, in pregnancy cases, et cetera, and of less value in secondary TMA, et cetera. And let me shift a little bit now to talking about improving our diagnostic accuracy. This is a daunting field, especially for people who are not seeing these cases very often. It helps to see it quite a number of years, so you sort of get surprised at your reflexes. But if you're not seeing that many, the key is sort of differentiating between these, figuring out which cases are AHUS, which are TTP, et cetera. So I'm going to talk about a few different things. The first is the use of the plasmic score to rule in or out TTP. The second is sorting out, is the hypertension coming from the TMA or is the TMA coming from the hypertension? I'm going to try to clear up our understanding of post-BMT TMA, and then I'm going to conclude with a discussion of multidisciplinary TMA teams as a way to override each individual's reticence to sort this all out. So let's talk about the plasmic score. This paper is now from almost a decade ago. It's unbelievable. But basically, they developed a score looking at a variety of different variables that would predict a low Adams TS13 level. So this included a very low platelet count earns you a point, not too bad kidney function earns you a point, absence of kidney or organ transplant, absence of malignancy earns you a point. And basically in this series, in both their initial derivation cohort and in two external validation cohorts, if you score 0 to 4 on this scale, you essentially have a 0% chance of having TTP, of having Adams TS13 deficiency. So if you apply the score and they don't have it, it doesn't tell you what they have, it just tells you they're very unlikely to have TTP. The converse is true, and this is, I think, where the score really has a value. If you score a 6 or a 7, you have approximately an 80% chance of TTP. TTP is a medical emergency, right? I deleted a slide that talked about its high mortality rate in the French series. TTP is not something you want to wait days. This is hours in beginning treatment. So if you have a plasmic score of 6 or 7, that person needs to be on plasma exchange within hours to save their life. And in fact, in this series, if you look here, those who scored 6 or 7 had actually the best survival, I think, because of the rapidity of the diagnosis and onset of treatment. I love the other thrombotic microangiopathies, but we have time. It's not an hour-to-hour thing, it's a day-to-day thing. Okay, we're trying to save kidney function. They're trying to save patients' lives. So let me shift to this question of what came first, the hypertension or the TMA. I'm going to provide a little bit of clinical clues to this otherwise challenging area. And basically, this is a table of factors that make it more likely that hypertension is the cause of the TMA versus the reverse. So male gender, older age, not surprisingly, pre-existing hypertension or previously being on antihypertensive meds, especially when they're stopped, are factors that would make it more likely that hypertension is the cause. This next point is really important. Rapid improvement of the TMA after you get the blood pressure under control. I think a lot of TMA centers now, faced with these challenging questions, we bring the blood pressure down. If the TMA is getting better, we breathe a sigh of relief. If it's not getting better, we need to now start thinking about therapy with complement inhibition. If you get to the point of doing a kidney biopsy, if we see glomerular microthrombi, that's much more consistent with TMA as the cause rather than hypertension, and their absence might argue for the converse. LVH sort of fits with the hypertension and pre-existing need for blood pressure medications. And then finally here is that no requirement for dialysis is more typical of the hypertension cases rather than the TMA cases. So this can help you a little bit in deciding who needs complement inhibitory therapy and who doesn't. So let's shift to BMT. I felt for a long time this is about as clear as mud. It turns out if you read the literature of our colleagues who do BMT and our hematologists, it's actually much more clear, I'm going to reassure you, because they're seeing this exactly the same way we are, which was very reassuring to me. Why is it complicated? Because there's a lot going on in the endothelium following bone marrow transplant. This part here will look familiar to all of us. This is the alternative pathway of complement, the membrane attack complex, et cetera, blocked by eculizumab. This will look familiar as far as microthrombi and schistocytes, but a lot of these other inputs are unique to BMT and are treatable by different treatments. But when it turns out, when you survey what BMT specialists are seeing, this is a recent review where they summarized the various criteria that have been proposed over the last decade or so for diagnosing what they call transplant-associated TMA. I think for nephrologists, we have to call it BMT TMA because we think of transplant-associated as a different organ. But I want to call your attention to this final column, which is by Jodelet and colleagues, which was looking at a pediatric BMT population. But you'll notice it's the same criteria we're thinking about: schistocytosis, new onset anemia, new onset thrombocytopenia, increases in LDH, but notably, they're thinking about this, keep in mind with a pediatric population, when there's a presence of either hypertension or proteinuria. So they're seeing the kidney involvement, and that's triggering them to think about it, in contrast to all the other reasons to be thrombocytopenic and anemic, et cetera, following bone marrow transplant. And they make the case for checking soluble MAC levels, and if those are elevated, it argues towards this being BMT TMA. So this is from the original Jodelet paper. Basically, TMA on biopsy would suggest TMA as compared to other causes. Here are the 7 criteria I alluded to earlier. The presence of 5 of those 7 is suggestive of TMA in their wording, and especially when there's proteinuria and soluble MAC elevation, this is consistent with this finding. I'm going to skip this slide, which is just to highlight their approach, which is exactly the same as our approach. So let me just briefly speak about a TMA team before a few moments speaking about treatment. So why would a TMA team be important here? Well, for those of you who have seen tons of these cases, maybe you don't need a TMA team. If you haven't seen tons of these cases, it's really helpful to get colleagues' input involved, and this is how Dr. Francis and I began. This is a rare disease. The morbidity and mortality are very high. It's challenging to make these diagnoses accurately. I think that's particularly true in adults, where there's so many comorbidities and so many other reasons to have some of these lab findings. And importantly, as we all know in this audience, a delay in diagnosis means a delay in treatment, which means a higher likelihood of dialysis dependency. And finally, the field is changing so quickly that it's really worth having a variety of people to chat with about cases. So who do I believe should be on a TMA team? Well, for sure, hematology and nephrology. Very likely, whoever's in charge of access to plasma exchange. I would make a very strong argument for a clinical pharmacist. These other entities are possible. If you have a big transplant center and your transplant nephrologist is interested, that's an advantage. If your renal or other pathologist is interested in this field, that's great. And other people who can identify cases, whether rheumatology in the right medical center or high-risk OB could be involved. Just briefly, what our teams look like in practice, the various team members discuss the lab results, they review the smear. If there's a biopsy, they review it. The director of the plasma therapies is the one who makes decisions about yes or no to plasma exchange. The pharmacist helps with treatment with complement inhibitory therapy, assists with the workup of drug-induced TMA, and helps, as I'll talk about a little bit later, with vaccination and antibiotic prophylaxis. So if I come back to our case from 20 minutes ago, this case, the two of us as nephrology, as well as hematology, the blood bank specialist and the pharmacist evaluated the case. Everyone felt this was a transplant-associated TMA, a kidney transplant, not bone marrow transplant. And then the very next day, eculizumab was administered. There was a dramatic response in the platelet count and hemoglobin, enough so that we actually biopsied the patient, which confirmed the diagnosis of transplant-associated TMA. And he started on eculizumab. I think now is currently on ravulizumab, if I recall correctly. And his immunosuppression was switched. He was very transiently on a calcineurin inhibitor, but basically has been on belatacept ever since, with stable allograft function. His genetic testing revealed a polymorphism that's not known to be pathogenic, but certainly questionable in this case. And importantly, this diagnosis and treatment plan was made in less than a day. So there was really no delay at all. So let me just, I know we're running a little bit late on time. I'm just going to briefly talk about infectious risk of treatment and then how to, in whom to stop and not stop treatment. So I don't want to talk about complement inhibition without talking about the risk of meningococcemia. So this is data from a registry of people with PNH and AHUS who were treated for long times with eculizumab. And you can see here that the onset of meningococcal infection was about 1 year to 2 years into treatment. And in fact, as I presented here, if people are treated for 5 years, about 1% will develop meningococcal infection. This is despite the ACIP recommended vaccine schedule. So people are still at risk, and we have to alert our patients and educate them about this risk. And I'll talk about some other strategies in a moment. So we need to vaccinate with the quadrivalent ACWY vaccine for N meningitis, as well as this B vaccine. I'll point out that very recently, in the last maybe 6 months, 2 companies have developed a combined ABCWY vaccine, so all components in a single vaccine. And I really want to, for those of you who are facing these decisions and these treatments, it's really important to attend to the ACIP website to get the correct vaccine sequence. It varies depending on which vaccine you use. And importantly, not only are there variations in the initial series, there's an important point to booster these patients at intervals that are under constant evolution, but it's really worth paying attention to, because I think this is one of the slip-ups that we could potentially make. You want to vaccinate against strep pneumoniae with the 23-valent polysaccharide vaccine, and then prophylaxis with antibiotics, usually beta-lactams, is absolutely indicated during the period where the patient is not fully vaccinated and on therapy, which is the majority, right? These are not people where you have like weeks to think about while you're vaccinating. That's different from some of the other conditions where we're treating with complement blocking agents. This is almost always you're going to make a decision to treat before the patient is vaccinated. So virtually everyone needs some sort of antibiotic prophylaxis. One of the questions is whether that should be extended, and a lot of TMA centers around the country and around the world are actually using prophylactic penicillin for the entire duration of complement blockade based on reports from the CDC and others of non-groupable meningococcal infections, meaning you can give all the A, B, C, W, Y, and they get some other letter meningococcemia. Just going to very briefly talk about discontinuing therapy. Dr. Francis alluded to some of the mutations that are very serious. I want to highlight here in a series from France that those with the complement factor H had a very high rate of relapse after discontinuation. But I would say even more broadly, anytime a pathogenic variant is seen on genetic testing, there's a high risk of relapse if you stop, and you have to be very careful, including the factor H. A family history of TMA is another factor that might make you less inclined to stop treatment. And then finally, a patient who's had more than one flare of TMA is someone who maybe is not the ideal candidate to stop therapy. If you do stop therapy, you have to monitor quite carefully. No one has any prescribed regimen, but a lot of people start with multiple testing of CBC, LDH, and haptoglobin, maybe at biweekly intervals. If that looks good, you switch to weekly. If that looks good, you switch to every other week. But you have to be really, really cautious when you do this. So in conclusion, these conditions, AHUS and the other TMA syndromes, are quite rare, but very high morbidity and mortality. Secondary TMA appears to be much more common than primary. And the role of complement inhibitory therapy is not 100% clear at present with secondary TMAs, but maybe something you do in the early days to get the situation cooled off and then get them further out, removed from that trigger. It's a diagnostically challenging set of conditions, but we're aided by plasmic scores, multidisciplinary TMA teams, collaboration with colleagues from other divisions and departments who have different perspectives on this condition. And then briefly, just treatment dilemmas that we face are this infectious risk mitigation and when and how to stop treatment. So I think with that, we can stop and take any questions. Thank you. Anyone feel free to, if you'd like, to step up to the mic, and we probably have some things in the app as well.
Just in terms of what usually is the time frame in seeing TMA from bone marrow transplantation?
That's a great question. It seems to be quite variable, but it's sort of on the range of like 30 or so days after the transplant. It's not immediate usually. It seems to be something that's sort of like a, I don't want to say subacute, but It's something that occurs sort of at that sort of 30 to 60 day mark. Can be a little bit earlier, but sort of in the 30 maybe to 45 day period.
We have a few questions on the app. So the first one is from Zach. What clinical or lab evidence convinces you to stop eculizumab after about 6 months instead of continuing lifelong?
I could tackle this one, but I'll be curious also to hear your thoughts. I think it depends very much on the trigger. If it's a medication trigger or an infectious trigger, this is probably something where you're not going to require lifelong therapy. I don't make that decision myself until I have genetic testing results, though. Okay, so I will start treatment, have the idea that it may be 3 to 6 months in length, and if the genetic testing reveals something that's really scary as far as mutation, then I'm going to extend it substantially longer. If it's negative, that genetic testing, I will then cautiously discontinue somewhere in that 3 to 6 month mark.
Yeah. So it's a very good question. And our approach, I'll tell you our protocol in our hospital, for example. So everybody will get 6 months of therapy. Meanwhile, we have done our genetic testing. And if somebody has a positive genetic testing, you need to know if you stop the treatment, there is a 50% chance of relapse and recurrence. So I think here you have to be cautious. Are you dealing with somebody who has normalized his kidney function, had full recovery of his GFR, or is it somebody who's stuck young adult or a kid who's stuck with a creatinine of 2, 2.5, and then you have to weigh in that, like if the relapse happens, there's not enough reserve in this kidney to really allow him to go all his life without getting a kidney transplant or renal replacement therapy. So if they have negative genetic testing, the risk of any relapse or recurrence of the disease is less than 5%. So you can feel more reassured in those people, to go ahead and stop the treatment after the mark of 6 months. And, in all of them, if you stop, you have to stop in somebody who's reliable, who's going to come, get checked up. If they get sick, they need to come automatically and get their blood tested just for any signs of relapse or recurrence. Soluble MAC, some people say it could be a guide, like if you're stopping in the setting of an elevated soluble MAC, it could be a sign that the disease might recur. Some other studies have showed that soluble MAC fluctuates up and down even on treatment. So it makes it probably a less reliable marker, but you have to be cautious. If you're stopping in on a day where the soluble MAC is extremely high, probably if you decide to stop, you need to monitor more closely the soluble MAC and the patient clinically to make sure there's no relapse or recurrence of the disease.
Let me ask one of the other questions here. Several of them overlap, but there's a question maybe Dr. Francis can answer, which is, should healthy relatives with known complement variants be excluded from living kidney donation if they're asymptomatic?
So we do not accept, I think, Dr. Gordon, I forgot if you mentioned, we worked together in the same hospital before he left us, and, but we're still very good friends. So we dealt with this case together. I don't know if you mentioned that his sister ended up donating to him. I didn't pay attention. So this patient that Dr. Gordon presented, we covered him together. His sister ended up donating, and we still regret it till now, why we accepted her, but we didn't have evidence at that time that the guy has TMA until it recurred after transplant. And even his genetic testing showed polymorphism. Even if it shows variant of unknown significance, let's say you tested the recipient and he has those variants of unknown significance, and his donor, has variants of unknown significance, you should not accept him. Like you should not accept a live kidney donor with anything abnormal in their complement, variant of unknown significance, or the same mutation that caused the disease in the recipient. They should not be accepted. If you do the genetic testing and you know the mutation in the recipient and there's no mutation in the donor, although we don't know all the mutations, some centers would accept. But are you taking a risk? Maybe. But you can feel more reassured if your genetic testing is completely negative.
Quick question.
Yes.
Is a patient, let's say a C3G patient, if they have a factor H mutation, are they more likely to have a TMA, or is there any other correlation?
Yeah, I always ask this question to myself, honestly. I wish I know in detail the answer, but I can tell you that the predominant affected area in the complement factor H and C3Gen is the N-terminal, and the predominant affected area in AHUS is the C-terminal. As I told you, the N-terminal regulates the fluid phase of the complement. The C-terminal regulates the solid phase of the complement. That said, this is 80–90%. There is overlap where the same mutation can cause C3GN and cause AHUS. Why? I don't know. To be honest with you, I don't know what's happening biologically inside and how the complement regulation is happening in a way to trigger this versus that disease. But those are the rare. They're like maybe 10–15%. But the majority are usually N-terminal, C3, C-terminal, are solid phase AHUS, and factor H in particular.
Why don't we take one more question, and then we'll let everyone get off to dinner.
All right, I hope this question is important enough. But so screening, living donors, but also general population. So as you pointed out, this disease is rare, and definitely the various variants of it are rare as well. So particularly for living donors, should we be screening all of them? It sounds like that would be ideal. But if not, what are like the clinical clues in a completely asymptomatic living donor that would point you towards screening?
Do we rule all of them?
Yeah.
Okay. It's if you do, you have to weigh a little bit also the importance of a kidney transplant, a recipient who is struggling on dialysis and going to wait 5–8 years now. It keeps getting longer and longer. So, but also you want to be safe and fair to the donor. And as I said, my guidance in our center, if we can avoid a live kidney donation, we try to avoid it if we can. But if we know the mutation in the recipient and we test the donor and then we don't find this mutation, we don't find any variant of unknown significance, we don't find anything alarming, we might accept the donor, and we do it with a very good consent. Like we talk to the couple and we say, listen, we don't know all the mutations. You might end up. Are you willing to take the risk? And if they understand their risks, it's like, for example, you have a family of ApoL1 and somebody is an ApoL1 positive and wants to give a kidney. Let's say a mom wants to give her son and she's ApoL1, G1, G2, or whatever form of the pathogenic ApoL1. They have 20% risk of developing kidney disease if they have the abnormal ApoL1. 80%, they won't have the disease. So a mother will tell you, I don't care. I want to save my son and I want to give my kidney. And it's not going to happen until maybe 20%. And if she's above age 40, the mom now, the risk of it happening, if it hasn't happened, is probably less. So, but unfortunately, I showed you in the complement, the penetrance can happen at 80, it can happen at 50, it can happen at 4. So it's hard. But if there's no genetic mutations in the donor, you can, with very good consent and explanation, accept this organ and save the recipient.
Okay. Well, thank you all for your attention.